Hello, hello, and a very warm welcome to our CytoSorbents webinar today. My name is Stefan Baudis. I'm VP Global Affairs at CytoSorbents, and I like to welcome you here in our webinar. The topic of today is a very hot topic, the use of CytoSorb in rhabdomyolysis. And before we start, I like to give you some information. We have a wonderful translator in the background. Peggy will translate from English into German. And in addition to that, please feel free to use our F&A button here on our screen to ask questions as much as you can. We will try to answer all your questions here. And with that, I like to welcome my dear colleague, Dr. Maria Soledad Taborda Küpper. She's medical manager for kidney and liver in our company. And she's an intensivist, and she will talk today about the background of rhabdomyolysis. She will also talk about the literature, of course. We have a lot of literature meanwhile. And we will also, of course, discuss with you many practical aspects, how to use CytoSorb in rhabdomyolysis. And with that, I like to welcome again Maria and hand over to you.
Hi, good afternoon, good morning for those listening to the west of the ocean, and good evening for those listening eastern of Europe. Without further delay, would like to bring you along in this session and discuss a bit on the CytoSorb therapy and its possibilities in the rhabdomyolysis field, which I personally consider a very exciting area of application for the hemoadsorption therapy. With that, our presentation will be briefly divided into sections. And in the first one, just a friendly reminder of what we are talking about, adsorber, the CytoSorb. And the concept is basically polymer-based absorption with divinylbenzene beads, porous beads, that enable to fix and to absorb selectively hydrophobic substances within a size range between 10 and 60 kilodaltons. And these beads and the pores within these beads enable not only for some size selectivity, but to amplify the absorption capacity. And as a friendly reminder as well, no filtration dialysis or selective ligand processes are involved in what CytoSorb does. Therefore, it can be combined with all possible blood purification technologies and extracorporeal support devices and platforms, because it can be added to them. It is a safe approach, not only in terms of the selection of the size, but also because the removal of substances occurs in a concentration-dependent gradient. So there will be never a complete elimination of any substance, whether endogenous or exogenous. And also important to highlight, the beads and the polymer are highly biocompatible, meaning that will not induce any foreign body reaction and will not induce activation of complement or similars by themselves. And within this frame of hydrophobicity and this size range that we have mentioned, some substances, including exogenous and endogenous, can be targeted. And amongst them, and maybe you have seen this in our marketing materials, but also in our instructions for use, these substances belong to the current approved use of CytoSorb. And within them, some of you maybe have heard of the technology in the context of hyperinflammation or cytokine removal, or from the cardiac surgical field, the removal of Ticagrelor or Rivaroxaban. But here I would like to address the myoglobin removal. And our documentation considerations for use enables you to obtain more data in which substances are included within this frame. And with that, in knowing that we can target the myoglobin removal, the question is, how do we transfer this knowledge from the technical standpoint to what happens in daily practice? And the first question in rhabdomyolysis, and I have to address that on the beginning, because what is rhabdomyolysis? We know, if you ask the classical definitions, that there is a condition where there is a direct or indirect injury to muscular tissues. That can be life-threatening, whose statistics are unfortunately not clear. One could say roughly 10 to 25% of patients in the intensive care unit that might need renal replacement support therapy might be affected also by rhabdomyolysis of a variety of causes, but this is not clear, varies greatly between populations, and there is a lot of under-documentation on the topic. In a pragmatic standpoint, from a pathophysiological view, it's the breakdown and the necrosis of muscle tissues with the release of intracellular contents in the bloodstream. And from electrolytes, potassium and phosphate, to proteins, to hemiproteins like myoglobin, to enzymes like creatine kinase, like AST, lactic dehydrogenase, and aldolase. But how do we define rhabdomyolysis? And as you see, cutoffs are unclear and definitions are unclear yet. Unfortunately, and this is part of the problems, and this is part of the reason why we cannot properly say an accurate statistic. From a clinical view, we can acknowledge that muscular weakness, myalgia, and swelling are common symptoms if the patient is awake and can perceive it. But if our patient is not responsive and cannot report to us that he feels weak or that he has experiences pain. So we tend to take a trigger or a condition that increases the risk for rhabdomyolysis plus a lab value. And classically, we tend to refer to creatine kinase values and a cutoff value about 1,000 units or an increase of 5-fold above the standard or the upper limit as per the laboratory parameters or the laboratory references tend to be what we clearly define as rhabdomyolysis. And on top of that, we have another problem between rhabdomyolysis and severe rhabdomyolysis. Labeling as severe, something that might be life-threatening or that can pose a risk for the patient, we tend to add not specifically a value of the creatine kinase, but rather findings of acute kidney injury or myoglobinuria, assuming that there is a release of myoglobin in the blood. So from a pathophysiological standpoint, our first question is why we do not acknowledge creatine kinase or myoglobin as the cause. And the problem is the course of creatine kinase and myoglobin from the moment of the injury to the moment of the diagnostic of the patients is variable. And in this graphic, already has some years published from Dr. Yanoglu, it highlights where, from a pragmatic view, the problem is in the first 24 hours after the injury is when the myoglobin is released and reaches its peak into the blood. And the myoglobin has only a problem. It's the one related to nephrotoxicity, but it tends to have a decrease in the curve that we could or not attribute to clearance. And this happens within the first 24 hours. And after that comes the peak of creatine kinase. And this is what lasts days. And this is what we can track along in a patient that has rhabdomyolysis. And this is probably the reason why we use rhabdomyolysis definitions based on creatine kinase. So myoglobin might make more sense, but in the timeline might be too early to detect. And the creatine kinase, in the opposite, is an enzyme, it's not a protein, has a higher molecular weight, and tends to be seen as not directly responsible for the injury, but rather a marker of the muscular damage. Now, what happens when rhabdomyolysis occurs? If you take a look at the pathogenesis of the events, the release of myoglobin and enzymes into the blood leads to capillary damage. And yes, this can produce hypovolemia. And we tend to associate this with indirect and later kidney damage. But turns out that the hypovolemia per se produces also renal hypoperfusion, and a kidney that is not being adequately nourished is in higher risk of developing acute kidney injury. But on top of that, myoglobin likes to create TAM-Horsfalk protein complexes in the tubule. And the problem with these complexes is that they clog directly and visually when you go to the electron microscopy, you can see that complexes and granular casts being formed after the first hours, and this will only worsen over time, creating tubular obstruction. But on top of this, we have a third issue, and the third issue is that the myoglobin can also be the trigger for lipid peroxidation and inflammation, and this will lead to direct tubular toxicity. So we have three major causes being responsible of the acute kidney injury. Now, in the tubula, the problem is not only the myoglobin, but also the inflammation that can occur after the trigger or the event where the rhabdomyolysis has occurred. And the cause can be anything, can be traumatic, can be drug associated. But in all of these cases, once myoglobin is released into the bloodstream, not only oxidative damage is occurring in the tubula, including the production not only of radicals of free oxygen, but also of nitrogen. On the other hand, also release of pro-inflammatory substances, including cytokines like interleukin-1 and MCP-1, are being at the same time in a tisular level occurring, and this is leading to acute kidney injury. But on top of that, those same pro-inflammatory cytokines might have a systemic event because they might also be released in uncontrolled amounts. This might trigger systemic hyperinflammation. And when the patient has triggers that can further worsen this hyperinflammation, as an example, surgical stress or infect bacteria, shock, sepsis, this patient is in a higher risk of developing shock. Then we have two spectrum of the disease that cannot be addressed only with one simple measurement, that is creatine kinase. So the problem is more complex. Now, briefly, how do we manage rhabdomyolysis? This does not happen every day, but it happens quite often. Maybe this is a patient that had a crush injury. Maybe there was an earthquake or a natural disaster, and 20 patients arrive with an acute muscular injury that might develop rhabdomyolysis or not. It's not statistically common, but it indeed happens. And the first rule would be, if release of myoglobin in the bloodstream is the problem, then source control, trying to address what triggered the rhabdomyolysis, is the main cause. A common example could be a patient that after an status epilepticus develops a rhabdomyolysis. We need to control the condition that is creating the muscular damage, and it's not at the muscular level, it's to control the seizure activity. We tend to learn, or we learn quite often in orderly practice, that fluid resuscitation helps because myoglobin can indeed be cleared, or the urine output should play a role, but we have questions about it. Of course, we also learned that release of potassium, and especially complications that might arise from higher potassium levels, can be life-threatening. Example given, hyperkalemia in cardiac arrhythmias. So this is for us also critical. And not to forget, if there are complications like an acute compartmental syndrome, then the treatment goes in another direction, a fasciotomy. Or the patient ends up having criteria for renal replacement therapy, then we also might decide that this is the right way to go. Now, about the fluid resuscitation, one has to add a few comments on the topic. The first one is, this is what we do most commonly in daily practice. Every time that I had to treat a patient with rhabdomyolysis in the past, this was also common practice. Patient arrives, and if there is a relatively preserved kidney function, then we will start giving fluids. The only problem is that, though we know that we try to do this fast to reduce the vasoconstriction and to reduce the precipitation of myoglobin and the buildup of these casts and these protein complexes, we happen to not know yet what is the optimal fluid to give. Studies still are inconclusive whether chloride, sodium, or lactate are the optimal fluid to administer, but also the volume is unclear. Some studies can only address that there is a positive effect if we provide more than 10 liters of volume. But what is the purpose here? Probably is more pragmatic to say we aim at an urinary output, and if this urinary output is about 300 milliliters per hour, then we might be doing something already positive for the patient. As I said, it's easy, it's accessible, but we do not have clear yet, after so many years and so many trials, what is the right way to approach. regarding the fluid and the dosing. But we also have a second problem, the timing. We know that the earlier is the better. And ideally, and the studies that have been able to prove a positive impact of the fluid therapy in patients with rhabdomyolysis insist that we should try to start 6 hours maximum after the injury has occurred. Sometimes this is possible in an intra-hospital setting, but if the patient comes from an extra hospitalized setting, or if this is a mass casualty, it's challenging. But when possible, consider to start in pre-hospital care settings. Now, a good question is fluid resuscitation the only way? The first one is, if the patient has general contraindications for fluid overload, like patients with deterioration of cardiac function, we have already a condition, a patient that cannot receive too much fluids or that will develop pulmonary edema is a patient that is not candidate already for this. And this might happen also. These patients with congestive heart failure are patients that are polymedicated, that might be receiving medication that might be the trigger for a rhabdomyolysis. We have a second problem, saline solution that we mentioned before. There are studies that are still being done with that. We tend to say lactate is better. But why? Because if we give too much saline solution, then our risks of hyperchloremic acidosis increases, and it has been proven also that can increase the precipitation of myoglobin. So what we were trying to do to reduce the precipitation can actually only worsen it. And last but not least, and this is a very fascinating area of development, the potential damage that we might be doing to the patient with fluids. More and more studies, and I encourage you all to read a bit on the publication of fluidotherapy and endothelial glycocalyx damage from the group of Dr. Milford. It's very interesting to see how the intervention that we have deemed probably as one of the less dangerous over the course of years can indeed produce damage in a very microscopic level, in a level that we do not perceive as dangerous, damaging the glycocalyx and worsening the inflammatory response and even triggering coagulopathy. So it is not that we will start doing fluid therapy. It's a question that we have to be conscious that the intervention, even the interventions that we deem as safer, can still have pitfalls that we have to keep an eye on. Now, diuretic strategies mentioned before, and so the idea of forcing diuresis by means of alkaline, bicarbonate, or by means of mannitol sound attractive, and so the concept of decreasing the gas formation and reducing oxidation and vasoconstriction have been there since decades. It has a problem. They have not been demonstrated yet to be superior to fluid therapy. That in the case of bicarbonate. And in the case of the forced mannitol diuresis, it has been even seen that the benefits are uncertain. That still creates questions, well, whether this is the right way to treat the patient. So proceed with caution. Interventions still might generate problems. And not to forget, we were talking about diuresis induction by means of bicarbonate and by means of mannitol. If we try to enter with other diuretic strategy, for example, given loop diuretics, furosemide, also quite available, also quite accessible, the risk of aciduria and the worsening of the myoglobin precipitation is not to be overlooked. Then we saw that also before. Another common question is, okay, the patient with a severe rhabdomyolysis with acute kidney injury with criteria for the beginning of renal replacement therapy is there. Then we have to start by taking a quick look at what is the kind of acute kidney injury that we're talking. Assuming that the patient has acute kidney injury, and we will stage it accordingly based on the classification of the Kidney Global Initiative, if the patient has no signs of acute kidney injury or is in stage 1, the severity mild, we would treat this rather conservatively. Fluid resuscitation, alkaline diuretic, or other diuretic option. If the patient is in stage 3, we know already that there is criteria of starting any form of renal replacement therapy. What is available? Continuous replacement therapy or intermittent replacement therapy. And we might take decisions whether high flux or the use of high good old filters. But is that patient in the middle, in the stage 2, the one where we are not sure where to go? If it's too conservative, we might be losing the opportunity to rescue him. And if we are too aggressive, we might be doing damage. And this is the question that we always comes to the table. The extremes are easy to detect and the extremes are easy to handle. What is in the center is where we tend to have less certainty. What is the right way to go? Now, can the myoglobin be removed? Unfortunately, due to its low diffusion coefficient and due to its unclear in vivo distribution volume, cannot be removed with conventional CRRT strategies. Can be removed indeed when you, instead of using standard dialysis filters, apply medium or higher cutoff filters. When you aim, and the substance has a rough molecular weight of 17, if you aim to remove with filters between 18 and 45 kilodaltons, or higher cutoff filters, of course you have the chance to remove myoglobin. The problem that we need to also consider is that we are talking about pore size, and the bigger the pore, then more substances will be addressed, including substances that we would not wish to be removed. And attract your attention to albumin as a good example of a substance that if you're using a medium cutoff filter should not be removed, at least not dramatically. But if you're using a high cutoff filter, so they claim to be still under the 60 kilodaltons, there might be loss of albumin, and this has been clinically demonstrated. And with that, a question would be, then why? Let's integrate what we have heard of the absorption technology plus this clinical situation, the rhabdomyolysis. Why should I consider the use of CytoSorb in patients with severe rhabdomyolysis? You have the trigger, yes. And very, very summarized, you have a direct toxic problem, the release of myoglobin in the blood. And you have a secondary problem, a local inflammation that has the risk of becoming a systemic hyperinflammation, or that might be already a systemic hyperinflammation. And that will clinically most likely express not only as the direct clogging of the tubula by the complexes or by the casts, but also in acute kidney injury, a valuable tissue that when fails needs replacement. And maybe this acute kidney injury is deadly for the patient, and maybe the patient will not recover its renal function again, or might end up needing support for the rest of his life. And what can CytoSorb offer in this context? Basically, specifically binding the circulating myoglobin, not the CK, you saw already different cutoffs. CK, not a direct toxic agent, it's rather marker for muscular injury, independent from convection mechanisms, and I need to add combinable with other depuration technologies, can be integrated in CRRT or in any dialytic mode, but also enabling to remove the excessive levels, not all of them, of inflammatory mediators, allowing the kidney to recover, giving a possibility in these patients with severe rhabdomyolysis to remove the myoglobin and to restore function as soon as possible. That would be the proposal of, or the rationale behind using CytoSorb in rhabdomyolysis. Questions here, Stefan? Maybe something that you have seen in the chat?
Yeah, so far there aren't any question. Obviously, everyone is convinced what you said. So that's fantastic. Meanwhile, by the way, we have roughly 70 participants here in our webinar, which is great from 30 countries. But maybe I can ask one question. So imagine you could measure myoglobin and CK in your hospital. Yeah. So I think myoglobin would be the preferred parameter from your side because it's an earlier predictor of severe rhabdomyolysis. Is this the case?
When possible, yes. I think that the biggest caveat might be in some centers that there might be the possibility that they cannot perform routinary myoglobin measurements in patients with suspected rhabdomyolysis. But from a pathophysiological standpoint, makes sense that myoglobin, because of its involvement in the problem, should be the one whose level should be determined as soon as possible to take decisions based on how severe we label this rhabdomyolysis.
Yeah, it would be interesting to learn from our participants if they can measure all myoglobin in their hospitals. In case yes, that's of course then fantastic to have this parameter as an early predictor for severe rhabdomyolysis or even AKI then, yeah?
Yep.
Okay. Yeah. Can you say something about how fast myoglobin is compared with CK? According to your graphic, I would say 24 hours earlier. Is it correct?
Well, first, I do not aim to steal Dr. Yanoglu's fabulous work on the topic. It's a reference on the understanding how does this look from a laboratory stand level. So the argument here is from the moment that the initial trigger occurs, and again, assuming that is only one event where only one chronological damage has occurred in the muscle, the first of the substances that will be released from the muscle tissue into the blood will be the myoglobin. And assuming that there is no further or ongoing rhabdomyolysis occurring, this will be the one that will rise in the first hours, reaching its peak at the 12 hours approximately, and with an expected clearance, assuming that you have controlled the situation in the first 24 hours. This is the danger. Sometimes nephrotoxicity occurs before we even realize that rhabdomyolysis has occurred. And this can be the case, not necessarily in a mass casualty or in a cross injury, because these patients will be at least preliminary treated in the ER as soon as possible. But this might be the case with overload of exercise, their exertional rhabdomyolysis due to heavy physical activity or military activities. This might be overlooked. And in the moment where this patient arrives to evaluation, the myoglobin level might already be high, yes, or might be even normal, but the damage has occurred already. And this is the reason why for many definitions, CK, because tends to have a more stable plateau when it's elevated over time, tends to be used as diagnostic. The cautionary tale is it might happen that if we wait, knowing that there is a rhabdomyolysis trigger, for the CK to become clinically relevant, we might be losing the opportunity to treat earlier this patient, and we might be losing the opportunity to remove that myoglobin from the tubula, and we might be losing the opportunity to prevent the acute kidney injury.
Yeah, I think we will come to this aspect a bit later when talking about how to treat these patients with CytoSorb. So there is, let me check if there is another question. Yeah, there's a question from one guest here from Matthias from Essen. I would like to ask you, what is the advantage of CytoSorb therapy compared to high volume hemofiltration? I think you touched this point already, but maybe you can illustrate that a little bit more one more time.
This is a very excellent question that we will address in the literature a bit later. But in general, the problem with myoglobin or with rhabdomyolysis is what do we aim to obtain with the renal replacement therapy? If we aim to treat the patient in acute kidney injury that is having a hyperkalemia or that is in a very severe fluid overload, then our therapeutic goal with the renal replacement therapy is clear. And this is not what the mechanism of action of CytoSorb is. If we're using CytoSorb, it's because we are aiming to remove myoglobin, and this myoglobin removal shall help to recover kidney function. And in this context, the myoglobin removal, the high flux dialysis has been tried, and there are a couple of studies on the topic and more on the way that try exactly to establish this difference, comparing can I, with a high flux dialysis or combinations of high flux dialysis plus high cutoff filters or medium cutoff filters, be comparable with CytoSorb in terms of myoglobin removal? Yes, not only comparable. We have already seen in some data published already that CytoSorb can provide a much higher gradient of removal of myoglobin. And this can provide an advantage when patients are receiving high flux dialysis and still myoglobin levels are remaining high, because you have a tool that can enable to enhance that myoglobin removal. It does not change that the patient might have other targets for renal replacement therapy. And I don't want to say one is enemy of the other, are combinable. But if you are aiming to remove myoglobin, and by this myoglobin removal to aid with the recovery of the kidney, of the tissue, and the recovery of the kidney function, then the CytoSorb can offer an advantage to the high flux dialysis. And this is what, again, has been seen already by authors that have already shared their experiences with us.
Mhm. Yeah, thank you very much, Maria. I think we have to go on with your second part now.
Okay.
But again, please feel free to answer to ask questions here in the Q&A or button. And yeah, we have enough time today to talk about all these single details. That's very good.
Excellent.
Okay.
Okay, then let's move ahead to what does the literature and the clinical data has proven so far. From a first standpoint comes the question. Let's say that the patient has a septic shock that might secondarily present a rhabdomyolysis or not. And this is a very interesting case because this is how these evaluations started. This was already 2016. And one of the first reports addressed specifically that a patient already with fulminant septic shock, with acute respiratory distress syndrome, with kidney injury already stage 3, and where in the context of rhabdomyolysis, presumably secondary to the sepsis, the decision is made by the clinician, I need to start renal replacement therapy, but the patient might benefit from additional tools to remove myoglobin. And I want to bring your attention to, this has moved further than expected, but the upper level. Please look at the value where they started. And the reference value, 23 to 72 of normal myoglobin at the first day of treatment. Take a look at how high was this myoglobin level, 30,000. Patients received treatment from day 1 to day 5, 1 absorber per day, and to the 12th day. So the myoglobin was high and did not met so fast the normal value because there is still a clearance curve that has to be met. The patient's procalcitonin reduces, yes. IL-6 level were also measured. The patient was septic and also reduced, but myoglobin, and the disease is dramatical, 30,000 to not measured on the day 5, but 1,308, and from there all the way down without adverse events. And this is the argument here. The patient was receiving, had a clear indication to start renal replacement therapy, but on the light of these very high levels, the decision to contribute to the myoglobin removal with CytoSorb was made, and not only helped with the biochemical parameter, helped also with the respiratory, the kidney function, respiratory function, and also liver functions improved a bit. But mind also that the patient, when it started the treatment, began with a bilirubin on 85.1, that the last measurement taken on the day 6 was 12. So the message to bring here is for removal of substances that due to its physicochemical properties cannot be addressed with renal replacement therapy techniques, one has an option to complement the treatment. And these can relate to improvement of laboratory parameters, but also of clinical parameters. And this would be, for me, the key message that I would like to bring here is this severe rhabdomyolysis, your therapeutic arsenal has already made its peak. We do not have too many options that go higher than that. And in these cases, considering the absorption and using it as a tool to aim to help to recover this kidney function is valuable. Same in another patient with rhabdomyolysis, also treated similarly. Case report, of course, this is not quite common. Patients with rhabdomyolysis and septic shock. Also, decision was made on the light of having a clinical problem with a myoglobin that was high, and mind here, myoglobin was, on the moment that they decided to start to treat, 18,000. But also mind that the patient, though he was in septic shock, he did not meet criteria for renal replacement therapy. This is the work from the group of Dr. Kren. And the decision was made, okay, we do not need necessarily to apply this tool in a dialytic treatment because the patient does not have criteria to start renal replacement therapy. They did a standalone hemoperfusion treatment with clinical improvement and look from a myoglobin of 18,000 to 387 on the day 15. Also with improvement of respiratory, renal, and liver functions. Other type of case report, and I bring it because of what I find personally interesting, that this was done in ECMO, is a patient in postoperative time after orthotopic heart transplantation. Patient presented a primary graft dysfunction, post-transplantation transient cardiogenic shock, and on the second day of the postoperative, creatine kinase and myoglobin are extremely high. Pre-treatment, 380,000 of myoglobin. Decision was made towards applying CytoSorb in this patient in the ECMO circuit for 4 days. They managed to recover considerably measurements and looked 330,000 to 53,000, massive improvement after 4 days. And then the patient recovered kidney function and was able to clear the rest on its own. I also want to bring this potential because a common question that might arise from using absorption therapies is this dangerous in highly polymedicated patients regarding other drugs? And one of the first remarks from this experience was plasma drug concentrations of the immunosuppressant therapy were stable during the whole treatment period. Further than that, without signs of organ rejection, and the patient had a follow-up time prior to this publication of 6 months without events. And like I say, I want to bring the message for me is, let's bring a tool that can be integrated flexibly in platforms to those cases where our therapeutic arsenal has already run out. It's a safe and feasible technique to help purifying the blood, and that can help you to preserve kidney function. Another case report, quite interesting as well, in traumatic rhabdomyolysis, and a bit addressed to the question before. In this specific case, a patient that had a cross injury, had an aortic inviolate dissection, starting values of myoglobin, as you see, skyrocket high. The patient was receiving CRRT and was receiving high flux dialysis plus a high cutoff filter. And you can see here, depuration and behavior of myoglobin and CK during the time where he was receiving high flux dialysis plus high cutoff filter. And what makes really the difference in the decrease was integrating the CytoSorb. So we can do this in patients that do not have criteria for dialytic treatments, yes, but we can also combine and we can also integrate in patients that have already started renal replacement therapy and where we have not been able to aim to obtain the recovery that we wish to. Take a look at that. The insufficient clearance was the reason to add it on the second day, not on the first day. And you see the difference from 110,000 to 65,000 in 4 hours. At 12 hours, they did exchange because there was what they define as a second peak, probably saturation. And then decreased to 70,000 in 12 hours. And parallel, this patient that was in a really critical condition, in shock, presumably hypopolemic, on the context of this crush injury and this dissection, could recover also from this vasoplegic shock, from this hypopolemic shock as well. It could reduce the vasopressor's need. So it can help. And the conclusion of the authors was not only that it helped, but was, in their opinion, more successful than what they were doing with the high flux dialysis plus the high cutoff filter. Another interesting case report, also following traumatic rhabdomyolysis, brings us also to another interesting case. What happens when you have a rhabdomyolysis, very severe, with a very clear cause, sportive trauma, orthopedic surgery, and the patient in the postoperative develops not only rhabdomyolysis, but an acute compartmental syndrome. For the compartmental syndrome, definitely cytosorb is not the treatment. Fasciotomy is the right way to proceed. But if the patient needs to be cleared of myoglobin, and you have the opportunity to detect this fast, and this was critical here, they could pinpoint what was the trigger. They did not have to wait for the values of creatine kinase to rise so high, and they go directly and treat. Look at the difference at the admission and the moment where they decided to start CytoSorb, and in this case, they only did 24 hours of treatment, only 1 day. They started with a creatine kinase at 79,000 and with a myoglobin over 22,000. And prior to the hospital discharge, already normalized. They do not need to replace the renal replacement therapy. It's an add-on, that can help with a very concrete problem that cannot be met with renal replacement therapy. And once the patient is improving, can be taken off, the therapy of absorption can be paused or stopped, and the rest of the supportive therapies can continue. And with an interesting conclusion as well, early use could help to prevent aggie instead of just treating the aggie afterwards. This is the critical point here. The question is, do we wait until the patient develops acute kidney injury when we know that there is a rhabdomyolysis event that will be severe or that we have measured and that we know that is severe? This is food for thought. We might be doing something that only sitting and waiting for the acute kidney injury to occur. They are also being used in pediatrics, also very interesting report. 12-year-old male, also a traumatic event, also underwent surgical treatment and physiotherapy when needed, and look at those starting levels, more than 12,000 of myoglobin, more than 42,000 of CK. In this patient, there was no clear criteria to start renal replacement therapy, but the decision was done to start a relatively low flow renal replacement therapy for the sake of using the CytoSorb in this patient. And take a look at the trend of decrease. 12 hours already shown a positive impact on the reduction. And very interesting to see as well, there was a peak they document after these 12 hours. And this peak suggests that the absorber might have been saturated as well. And they took the right decision. They treat the patient. The patient is showing that the therapy is not longer providing the result that you are looking for. They replace the absorber, and with a second absorber, they manage to complete the treatment. And the patient is discharged with normal values, with a recovered kidney function. So it is not sufficient to find out when to start. It is also an interesting concept that we implement actually in the care of our patients. Treat as much as needed and replace or intervene as much as needed. This is why we're in critical care. And a very interesting conclusion from them as well could be considered to impede the development of aggie. As said before, we do not have to sit and wait until aggie occurs. We can do something proactively in these patients. Another interesting case series from the group of Dr. Scharf is a case series, was published last year, already addressed 43 patients. These patients had very concrete criteria to enter this case series. First of all, they were in stage 3 aggie as per the KDIGO definition. Of composite of causes, traumatic and not traumatic. Common thread, myoglobin over 5,000. Patients with criteria of starting CRRT with high flux dialysis, plus CytoSorb, and some of them might have been receiving support with ECMO or not. And by the difference, there was a considerable decrease of myoglobin. It is prior to treatment, moment of starting of the treatment, and reduction. The median relative reduction was of 29%. And this was similar for patients that were receiving ECMO support or not. But the conclusion is that can help, can be recommended, not only because it provides effect, but because it's authorized for this use, because it's easy to integrate, because it did not have relevant side effects for them. And this group is also working towards very interesting data that we cannot spoil the cake, but it also is able to tell us a bit more about which group of patients will benefits from this intervention more. And like I said, only brief spoiler, myoglobin matters. A patient that only has a mild risk of myoglobin will not most likely be the one that benefits from a concentration-dependent removal technology like CytoSorb. But the higher your myoglobin, the better the patient response. And this correlates from a pathophysiological standpoint. The patients with very high circulating myoglobin are the patients that most likely will suffer the most damage from the myoglobin precipitation in the kidney. And another common question is, okay, we have seen before that there is a possibility to remove by adsorption or to remove with filters that can provide median or high cutoff. This was also tested, and this was an article published this year. Address a small case series, yes, 15 patients. Criteria for inclusion was that these patients had criteria for renal replacement therapy in the context of severe rhabdomyolysis. Also a composite of traumatic and not traumatic causes. And all of them had as a common thread even higher value of myoglobin, more than 20,000. These 3 devices were put in 3 arm groups to see what happened. a high cutoff filter, a medium cutoff filter versus CytoSorb. And the results show that all the three of them can indeed remove myoglobin. Yes, you please pay attention. The high cutoff filter, of course, removes. The medium cutoff filter, as expected, the gradient of removal is lower, yes, but of course, and with the CytoSorb, at least the plot clearly shows that the gradient also occurs. So one simple conclusion, very pragmatic, could be this. All devices could achieve a myoglobin reduction above 50%. One also needs to talk about some caveats and some details that also belong to this. The first one is patients that were receiving treatment with dialysis, high flux dialysis, plus the use of a high cutoff filter, were already deemed as patients that would have a clinically relevant albumin loss that needed albumin replacement. So we treat, but we create a side effect that needs a further intervention. And medium cutoff filters were, of course, in comparison with the high cutoff filter, more desirable because their albumin loss is lower, but also their myoglobin removal is lower. And another interesting conclusion of the effect is that CytoSorb, in contraposition, without going in details if the removal is bigger or not, I think the plotting graphic is much more contundent than my words, has a greater surface capacity and can provide immunomodulation as well, that are aspects of the pathophysiology of the rhabdomyolysis that cannot be completely met with high cutoff filters or medium cutoff filters. As Stefan promised, some practical considerations that I think that we can all take a look and integrate in daily practice, and I think that apply very concrete for almost every intervention in acute patient care, is the first patient selection. Who are we treating? And currently, how the best practice looks like suggests that patients that have more than 10,000 of myoglobin benefit from the myoglobin removal. And I have to add here cautionary tale. If you wait until creatine kinase reaches this 5-fold increase value or more than 1,000 units to make the decision of label as rhabdomyolysis, you might be treating too late. So it is possible that you will see that the diagnostic of rhabdomyolysis will only occur on the context of creatine kinase and decide accordingly. But if you happen to have the opportunity in patients where there is a clinical suspicion of rhabdomyolysis to measure myoglobin and to get value of myoglobin before the increase of CK, and then it looks like this patient might benefit from the myoglobin removal, especially in an early phase before damage has really occurred. As known from previous experiences, not only for rhabdomyolysis, but for non-rhabdomyolysis applications of CytoSorb, if the patient has a refractory vasoplegic or septic shock, unresponsive to conventional therapy, does not belong to the scope of this presentation, but want to bring attention. If the patient on top of this presents a second possible argumentation for hemadsorption, worthy to integrate in our decision-making process. The same for renal function impairment. We do not have the same tolerance range to see what happens with the kidney function when the patient is already known to have a chronic kidney disease, because rhabdomyolysis might be the trigger for the patient ending up in end-stage renal disease. And this is also something that we might need to bring into our decision-making process. And maybe the easiest one, if the patient by any chance arrives and is in a possibility to treat because it has already developed acute kidney injury with renal replacement therapy criteria, then this patient has more points in our decision-making process to consider hemadsorption. Same with timing. Like with everything, prioritize an emergency situation. If the patient is in refractory shock, or if the patient has an urgent indication for acute kidney injury, the problem is already there. This patient might benefit from starting as soon as possible. And as seen in this interesting case of applying in patients that this patient that did not have kidney injury before, if the criteria is met before, like in shock, but not yet in kidney injury, or very high myoglobin values, but not kidney injury, might benefit also, and I want to emphasize might, but that chance of trying to reduce or possibly prevent the risk of acute kidney injury is valuable. We might be doing something early and not only waiting until the damage has occurred. And as highlighted also with some of these case reports, the dosing. How to continue? Hard to tell. Depends on how much is circulating on the patient. Depends on if the cause is controlled or not. a patient that has a traumatic limb injury, that the rhabdomyolysis occurred after the surgical stabilization, where there is no further release of myoglobin in the blood, looks like will benefit from shorter periods of treatment. A patient that is still with ongoing rhabdomyolysis, that is still shocked, that has a higher degree of kidney function impairment, might need a longer treatment. But we do not measure this with a rule of thumb. We have to take a look at how the patient is looking like. Is clinical improving? Is the urinary output what we aim to have? Is the hemodynamic stabilization in the case of shock patients obtained? And probably the best answer is reevaluate early. 24 hours between reevaluation and decision towards modifying the intervention is of course too late, not only for this, for almost everything. Reevaluate early. Take a look at the patient after 8 and 12 hours. If you have the possibility to measure control myoglobin, take a look. It might be signs of saturation that might prompt this patient benefits from an early replacement. I think that is the logical thing to do, even if one might receive the wrong impression that because something lasts 24 hours will always last 24 hours. I would say, let's treat patients first, and not only flow charts and not only lab values. Is the patient who will lead the treatment. And as a summary, I would like to highlight these 4 key concepts. And as you saw, rhabdomyolysis is not only a challenge in the diagnostic, but in the treatment, because there is still a considerable lack of consensus in both ends. Hypermyoglobinemia, not only myoglobin values, high myoglobin values, plus dysregulation of the immune response are very, very important to understand how and when the kidney injury occurs. The hemoadsorption is a powerful approach that targets the myoglobin removal and immunomodulation in these patients. And so far, though case series and case reports are still undergoing, so there are more trials to come in the next month, but the preliminary signs are it's helping to improve not only biochemical parameters, but also clinical. A patient whose kidney function recovers and whose outcome is better is a patient that we have done our job. And like everything, this, I need to say, this is no specific for hemoadsorption, but for everything that we do in critical care, patient selection, timing, and dosing. Which patient benefits from an intervention, cost, regardless of complexity? When is the right moment to treat, and how much of this treatment should be applied? And with that, I would like to close to remind you that all of these infos and publications that we have discussed today are available in our literature database, and looking forward to your questions and your comments. Thank you very much.
Yeah, thanks a lot, Maria. That was a lot. But I think you underlined very well that CytoSorb can really make a difference in this rhabdomyolysis situation, also compared to high cutoff filters, for example, and the other filters which are currently used, of course. Yeah. So I'm very thankful for that and all the details. It's nice to see that there's ongoing progress with publications. More and more case series are occurring, and I think, as you said, we can expect more because it's obvious that it's working. Yeah, the CytoSorb is doing the job, so to say. Yeah, and I think you underlined also very clearly how to use it. It should be also a kind of personalized or individualized therapy, of course. Yeah, this is also the case for many other indications in critical care. But the good thing with CytoSorb, I think, is also that the system, the technology is flexible. So whenever a CRT is running and you have the feeling it's not enough, you can add it to the running system. Yeah. Or you can start from the beginning with CytoSorb and CRT. Yeah, I think that is a big advantage for every user. And at the end of the day, you underlined it as well. It's a safe method. And in regard of rhabdomyolysis, it's also a very, I think, specific removal. Sometimes we say it's an unspecific removal, but to target myoglobin, for example, is a very specific approach. I hope you agree.
I do.
I was just checking the Q&A here, and there aren't any questions, which speaks for itself. So obviously you convinced everyone here in this round. But again, feel free to come back to us and let us know your questions, and maybe there are also some technical questions. We are ready to answer all these questions because we have, I think, a lot of experiences now. I think we know a lot of stories, patient stories, where we could see with our own eyes that CytoSorb could really help these patients in addition to the standard of care, we have to say, and that is counting at the end of the day. So I think, as stated in the beginning, I think the indication of CytoSorb in rhabdomyolysis is a wonderful indication, and it shows how useful the therapy can be. And you pointed it out, sometimes it's also important to have a kind of immunomodulation aspect. And this is, of course, the core of CytoSorb, so to say. We know that since many years. If there aren't any questions in this moment, I really like to finish here. I'd like to thank you one more time for the great talk, for this fantastic overview. I think you had a wonderful presentation here today, and we all could learn a lot. And I like to thank all the participants. So we had in medium more than 70 people here. And I like to thank also my dear colleague Attila, who was responsible for all the technical aspects of our webinar. And I like also to tell you that tomorrow, 3 p.m. Central European Time, we have another webinar. And the speaker is Maria again. She will talk about the use of CytoSorb therapy in liver dysfunction. I think that's another very interesting indication and topic. And I hope to see you all tomorrow here again. And if not, at one of our next webinars or symposiums at the next congresses. So, and with that, I want to say goodbye and all the best to you, and think about CytoSorb in rhabdomyolysis.
Thank you very much, Stefan. Have a nice day, everyone.
Bye-bye.